This free lecture is designed to give you a clear example of how we approach continuing professional development differently. At Clinical CPD Hub, we take evidence from across allied health, including osteopathy, physiotherapy, pain science, and exercise rehabilitation, and show you how to apply it in real clinical practice today. Because we all know there's no single magic technique, adjustment, or exercise that fixes every patient. What matters is understanding when to apply different approaches and how to build better clinical reasoning around patient care. So whether you're listening to the full lecture, watching the video, or using the MP3 version through the free registration, we hope you find it practical, concise, and clinically useful. And remember, if you'd like to complete this lecture as a CPD activity, including access to the PDF summary, reflection questions, and quiz, you can register completely free at clinicalcpdhub.com. No payments, no subscriptions, no credit card details required. Now, let's get into the lecture.
Welcome to today's lecture, Why Neck Pain Treatments Don't Hold, Expanding Clinical Reasoning Beyond a Single Lens. Developed by Clinical CPD Hub and Dr. Philip Deem. Total CPD time 1 hour, depending on reflection completion. Learning format, audio lecture, clinical summary PDF, this document, clinical guide, practical application, multiple choice quiz, learning outcomes. By the end of this lecture, clinicians should be able to recognize the difference between short-term treatment response and long-term retention in neck pain presentations. Identify the limitations of a purely structural approach when managing recurrent or persistent neck pain. Understand how neurophysiological factors may influence presentation, response to treatment, and symptom persistence. Apply an integrated clinical reasoning framework using structural, system, neurophysiological, and adaptation lenses. Develop a clearer approach to supporting long-term change through improved clinical decision-making. 1. Introduction. The clinical problem neck pain is something most of us see every single day in clinic. It's familiar, it's common, and in many ways it sits right in the wheelhouse of what we do as osteopaths. We assess the structure, we find restriction, we treat it, and a lot of the time it works. Patients walk out, moving better, feeling looser with less pain. There is strong evidence to support this. Manual therapy, including mobilization and manipulation, has been shown to improve pain and function in people with neck pain, particularly in the short term, as demonstrated in systematic reviews such as Gross et al. 2015, Manipulation and Mobilization for Neck Pain. So this isn't about saying what we do doesn't work, because it clearly does. But here's the part that most clinicians will recognize. You get the change, but it doesn't always last. The patient comes back a week later. Sometimes it's the same pain, the same restriction, the same pattern, and if you're honest, you've probably had that moment where you think, I did everything right, so why are we back here again? Now, it's easy to explain that away. We might say, they didn't do their exercises, they returned to poor habits, or they simply have a recurrent presentation done. And sometimes those things are true. But when you see the same pattern repeated across different patients, it raises a different question. Is the issue really the treatment, or is it how we're thinking about the problem? Because if we look at the broader evidence around neck pain, we see a consistent theme. Neck pain often has a variable and sometimes persistent course, with recurrence and incomplete resolution being common, as shown in systematic reviews such as Hush et al. 2011. Prognosis of acute idiopathic neck pain. This suggests that short-term improvement does not necessarily reflect long-term change, and that distinction is important because it shifts our focus from did the treatment work to was the change meaningful enough for the body to keep. Osteopathy gives us a strong foundation for understanding structure and function. But if we view neck pain purely through a structural lens, we may miss other factors that influence how that presentation behaves over time. Evidence from across allied health suggests that neck pain is often influenced by multiple interacting factors, including physical, neurophysiological, and behavioral components, as highlighted in prospective research such as Shahidi et al. 2015 Risk Factors for Chronic Neck Pain. So this creates a shift, not necessarily in what we do first, but in how we interpret what we're seeing. Because getting someone better in the short term is one thing, getting the body to hold on to that change is something else entirely. And that's what this lecture is about, not new techniques. Not a different adjustment, but a slightly different way of looking at the same patient. Section 2. Understanding the concept. So let's build on that idea. You treat the neck, you get a good response, pain drops, range improves, the patient feels better. By most measures, that's a successful treatment. But then, a few days later, or a week later, they're back. And the question we have to ask is, what actually changed? Because something clearly did. We saw it, they felt it. But whatever that change was, it wasn't strong enough or meaningful enough for the body to keep. What are we actually measuring? In practice, we often measure success based on immediate pain reduction, improved movement, or how the patient feels at the end of the session. And those things matter, but they don't always reflect lasting change. More often, they reflect short-term changes in pain perception, temporary reductions in muscle tone, or local mechanical effects. There is good evidence that manual therapy can produce these short-term improvements in pain and function, as demonstrated in systematic reviews such as Gross et al. 2015, Manipulation and Mobilization for Neck Pain.
Just a quick pause in the lecture. If you'd like to complete this session as a CPD activity, including access to the clinical summary PDF, reflection questions, and short quiz and certificate, you can register completely free at clinicalcpdhub.com. No payments or credit card details required. Now, let's get back into the lecture.
So again, what you're doing is working. But here's the key point. Those improvements are not always maintained over time. Looking at the bigger picture. If we step into the broader evidence, particularly around rehabilitation and long-term outcomes, a consistent theme emerges. Exercise-based interventions have been shown to support improvements in pain and function in people with mechanical neck disorders, particularly when applied over time, as outlined in systematic reviews such as K et al. 2012 Exercise for Mechanical Neck Disorders. But even here, the wording matters. The evidence doesn't suggest that any single intervention consistently resolves neck pain long-term. Instead, it suggests outcomes tend to improve when change is reinforced and progressed over time. And when we combine that with what we know about the natural course of neck pain, where recurrence and persistence are common, as shown in Hush et al. 2011 Prognosis of Acute Idiopathic Neck Pain, we start to see a clearer picture. Reframing treatment. So instead of thinking about treatment as fixing the problem, it can be more useful to think about it as creating a window for change. Manual therapy may reduce pain, improve movement, and allow the system to temporarily behave differently. But what happens after that window opens? Because if nothing follows it, no reinforcement, no integration, no progression, then the system often returns to what it knows. The clinical reasoning shift. This is where your thinking starts to change. Instead of asking, did my treatment work? We start asking, what did my treatment actually change? How long is that change likely to last? What needs to happen for that change to be retained? And this is where you begin to recognize something important. A recurring neck pain presentation is often not a failed treatment, but an incomplete process, where change was created but not supported. Why this matters? Because once you see it this way, it changes how you approach every patient. You stop relying on the immediate response, assuming improvement equals resolution, and you start thinking ahead, planning beyond the session, and building towards retention. Section 3, Assessment and Clinical Reasoning. So let's come back to the first lens we all rely on, the structural lens. This is where osteopathy is strong. We're trained to assess movement, identify restriction, feel changes in tissue, and interpret what we find. A patient presents with neck pain, and quite naturally, our attention goes to the cervical spine. We look for segmental restriction, increased tone asymmetry, and reproduction of symptoms. And more often than not, we find something, we treat it, and we often get a response. So it's very easy to assume that was the problem. Where this can fall short, but this is where I want you to pause for a moment, because just because we find something, and just because it changes with treatment, doesn't necessarily mean it was the primary driver of the presentation. Sometimes it is, but not always, and this is where the structural lens on its own can start to limit us. Expanding the structural view. If we step slightly outside the cervical spine and look at the broader literature, there is evidence suggesting that interventions targeting adjacent regions, particularly the thoracic spine, can influence outcomes in people with neck pain. Systematic reviews and meta-analyses, such as Masaracchio et al., 2019. Thoracic spine manipulation for mechanical neck pain indicate that thoracic manipulation may contribute to improvements in pain and function in individuals with mechanical neck pain. Now again, the wording matters. This does not mean the thoracic spine is the cause of neck pain. What it suggests is the cervical spine is influenced by the system it sits within. What this looks like, clinically, think about a patient you've seen recently. They present with unilateral neck pain, reduced rotation, increased tone through upper trapezius or levator. You treat the cervical spine, you get improved movement, reduced pain, decreased tone, but nothing else has changed. The thoracic spine still moves the same way. The load through the upper quarter hasn't shifted. So when the patient returns to their work, their posture, their normal movement patterns, the system behaves exactly as it did before. And over time, the same pattern reappears, the clinical reasoning shift. So instead of asking where is the restriction, we start asking what system is this neck part of? Where else might load not be shared effectively? What hasn't changed outside of the local treatment? And that might lead you to consider thoracic contribution, rib mechanics, scapular involvement, not because we're chasing additional findings, but because we're trying to understand the environment the neck is operating in. Why this matters for retention. Coming back to our core question, why doesn't the treatment hold? If the only thing that changes is the local joint, the local tissue, or the local movement, but the broader system continues to load the same way, move the same way, and behave the same way, then it's not surprising that the body returns to baseline. So again, the issue isn't that the structural treatment was wrong, it's that it may not have been enough on its own. Important clarification. This isn't about stepping away from osteopathy, it's about refining how you apply it. Your ability to assess, feel, and treat is still central. But when you combine that with a broader structural view, you move from treating isolated findings to understanding how the system supports or undermines your treatment. Section 4, Clinical GAMRP 2, the neurophysiological lens. So once we move beyond the structural lens, the next layer to consider is something a little less visible, but something you're already interacting with every time you treat a patient. And that's the state of the system, what you're already seeing in clinic. Think about the patients who don't quite behave the way you expect. The ones where everything feels tight, movement is guarded, there's no clear structural pattern, and small movements seem to provoke a bigger response than you'd anticipate. You treat them. Sometimes they respond really well, sometimes the response is inconsistent, and sometimes nothing seems to hold. Traditionally, we might describe this as increased tone protective guarding or just a sensitive presentation. And those descriptions are useful, but they don't fully explain what's happening. What the evidence suggests. If we step into the broader literature, particularly around pain processing, there is evidence to suggest that individuals with non-traumatic neck pain may demonstrate differences in how pain is processed within the nervous system. Systematic reviews and meta-analyses, such as Xie et al. 2020, Central Pain Processing in Neck Pain, indicate that altered central pain processing may be present in some individuals with neck pain. Again, the wording matters. This doesn't mean every patient is centrally sensitized, the problem is purely neurophysiological. What it suggests is the nervous system may be influencing how the presentation behaves, bringing it back to what you feel. Now think about what that means clinically. If a patient is in a more protective or heightened state, then what you feel with your hands might not just reflect a joint restriction or a local tissue change. It may also reflect increased neural drive, altered threat perception, or a system that's trying to protect itself. And this is where things start to connect. Because when you treat that patient, you often see tone, reduce movement, improve pain, settle Lou, which tells us something important. You've influenced the system, what actually changed. But here's the key question again. What did you change? Did you correct a structural issue, or did you temporarily reduce a protective response within the system? In many cases, it may be a combination of both, but the evidence suggests that pain and movement can be influenced through mechanisms beyond purely mechanical change, particularly in individuals with altered pain processing. So again, what you're doing works. But if the underlying state doesn't shift enough, the effect may not persist. Why this matters for retention. Coming back to our central question, why don't treatments hold? If a patient's system remains in a protective, sensitized, or heightened state, then even if you improve range of motion, local mechanics, or tissue tone, the system may still interpret movement as something to guard against. So over time, it returns to stiffness, restriction, and familiar patterns, not because the treatment failed, but because the system reverted to its previous state. The clinical reasoning shift. So now we start asking slightly different questions. Instead of, what structure is the problem? We add, what state is this system in? Does this feel more protective than mechanical? What might be maintaining that protection? And again, this doesn't replace what you already do. It adds another layer to how you interpret what you're feeling. Keeping it grounded. This doesn't mean overcomplicating your treatment or moving away from hands-on care. It simply means recognizing that not all restriction is purely structural, and not all change is purely mechanical. Sometimes what you're seeing is the system adapting, protecting, and responding to perceived load. And when you view it that way, your role shifts slightly. From fixing a structure to influencing how the system behaves. Section 5, Clinical Gember 3, the adaptation lens. So now we've looked at the structural lens, the system around the neck, and the state of the nervous system. The final piece, and the one that really determines long-term outcomes, is this adaptation. Because at the end of the day, the question isn't just, did we create change? It's, did the body adapt to that change? Change versus adaptation. This is where a lot of treatments fall short. As clinicians, we're very good at creating change. We reduce pain, improve movement, decrease tone, and often we can do that quite quickly. But adaptation is a different process. Adaptation requires repetition, appropriate load, and time. Without those elements, the body has no strong reason to hold on to what you've created. So what you often see is a temporary improvement, followed by a return to baseline. What the evidence suggests. If we step into the broader literature, particularly around exercise and rehabilitation, there is evidence suggesting that active interventions can support improvements in pain and function in individuals with mechanical neck disorders. Systematic reviews such as Kay et al. 2012, Exercise for Mechanical Neck Disorders, indicate that exercise may contribute to improvements in pain and functional outcomes, particularly when applied over time. But again, the wording matters. The evidence does not suggest that exercise alone consistently resolves neck pain long term. What it suggests is improvement is more likely when change is repeated, reinforced, and progressed. And when we combine that with what we know about the natural course of neck pain, where recurrence and persistence are common, as shown in Hush et al. 2011, prognosis of acute idiopathic neck pain, we start to see the bigger picture. The missed opportunity in practice. This is where I think a lot of us run into a ceiling. You treat the patient, you improve their movement, reduce their pain, normalize tone, and at that point, the session feels complete. But from an adaptation perspective, that's actually the start of the opportunity. Because right after treatment, the system is in a different state. Less pain, more movement, less protection. And that's when the body is most open to change. If nothing follows that, the window closes. What happens without integration? If the patient goes back to the same environment, moves the same way, loads the same structures, without any form of progression or reinforcement, then the body does what it's designed to do. It defaults back to what it knows. So over time, the same movement patterns return, the same loads are repeated, and the same symptoms reappear. And from the outside, it looks like the treatment didn't work. But in reality, the change was never integrated, the clinical reasoning shift. So now the question isn't, what exercise should I give? It becomes, what does this patient need to adapt to? What load are they currently not tolerating? How do I build on the change I've just created? And that doesn't have to be complicated. It might be simple movement exposure, low-level loading, gradually reintroducing range. The specifics will always vary, but the principle remains the same. No adaptation, no retention. Connecting it back. Now if we zoom out and connect everything. Section 3 showed us that treating the neck alone may miss the system. Section 4 showed us that the system's state may influence how it responds. And now Section 5 shows us that even if we change both of those, without adaptation, the system still returns to baseline. So the issue isn't one thing in isolation. It's how these factors interact over time, where this changes your practice. Once you start thinking this way, your role shifts slightly. You're no longer just creating change. You're creating change, supporting the system, and building adaptation. And that's where you start to see the difference between short-term improvement and long-term progression. Section 6, an integrated clinical reasoning framework. So let's bring this all together, because at this point, we've looked at 3 key areas: the structural lens, the system around the neck, and the state of the nervous system, along with the role of adaptation. And if you're not careful, this can start to feel like there's too much to think about. So what we want to do now is simplify it, not by removing anything, but by organizing how we think through it. From information to decision-making. In clinic, you don't need more information. You already have good hands, good assessment skills, and a strong understanding of structure. What you need is a way to prioritize what matters for that patient in that moment, and that's where a simple framework becomes useful. The 4-lens clinical reasoning model. When you're working through a neck pain presentation, you can view the same patient through 4 lenses, not as separate treatment approaches, but as different ways of interpreting what you're seeing. 1. Structural lens. This is your starting point. What is restricted? What reproduces symptoms? What changes with treatment? This is where osteopathy is at its strongest. You're identifying local dysfunction, movement limitations, and tissue behavior. And in many cases, this is where your initial treatment is directed. 2. System lens. Now we zoom out slightly. What else is influencing how this area is loading? What regions may not be sharing load effectively? This might include thoracic contribution rib mechanics, scapular involvement. You're no longer just asking what's happening at the neck, you're asking what's influencing the neck. 3. Neurophysiological lens. Now we consider state. Does this presentation feel purely mechanical, or is there a level of protection or sensitivity involved? You might notice widespread tone, guarded movement, disproportionate responses. This doesn't mean you stop treating. It means you interpret the response differently and sometimes adjust your expectations around how long that change will hold. 4. Adaptation lens. And finally, we look forward. What does this patient need to adapt to? What change have I created and how do I support it? This is where loading movement and progression come in, not as an afterthought, but as the step that determines whether anything you've done actually sticks, putting it together in practice. Now, the key thing here is you don't need to apply this in a rigid sequence. This isn't a checklist, it's a way of thinking. Some patients are primarily structural, others are more influenced by system or state, but in almost every case, adaptation is what determines the long-term outcome. A simple way to use this tomorrow. If you want to keep this practical, reduce it down to 4 questions. What am I seeing locally? What else might be contributing? What state is this system in? What needs to happen for this change to hold? That's it. You don't need more complexity than that. Why this works? Because once you start thinking this way, a few things change. You stop chasing the same findings every session, start recognizing patterns across patients, and begin to understand why some cases progress and others don't. And importantly, you move from reacting to symptoms to making more informed clinical decisions. Section 7, Practical Takeaways and Closing. So let's bring this back to something simple. Because there's a lot we've covered. We've looked at the limits of a purely structural approach, the influence of the system around the neck, the role of the nervous system, and the importance of adaptation. But at its core, this isn't about adding more into your treatment. It's about thinking differently about the same patient. What this looks like in practice. The next time you see a patient with neck pain, nothing needs to drastically change in how you start. You'll still assess, find restriction, and treat what you feel. That doesn't go anywhere, but what can change is what happens next. Instead of finishing the session thinking, that moved better, you start asking, what actually changed here? What might bring this back to baseline? What does this patient need to hold on to this improvement? And those questions naturally lead you into thinking beyond the local site, considering the state of the system and building something after the treatment. Keeping it simple. If you strip everything back, it comes down to this. Treat what you find, understand the system it sits within, recognize how the system is responding, and support the change you create. You don't need more than that. You don't need more techniques, more complicated rehab, or a completely different model. You just need a slightly broader way of thinking. The bigger shift. Over time, this starts to change how you practice. You stop chasing the same findings, repeating the same treatments, and wondering why things aren't progressing, and you start to recognize patterns earlier, make more informed decisions, and see more consistent outcomes. Not because you're doing more, but because you're thinking more clearly. Final thought, osteopathy gives you a strong foundation. This isn't about stepping away from that. It's about building on it. The goal isn't to replace what you already do. It's to refine how you think when you do it. Because in the end, better clinical reasoning leads to better clinical outcomes.
Thanks again for listening, and we hope you found this lecture useful. At Clinical CPD Hub, our goal is to provide clear, evidence-based education that clinicians can apply in practice immediately. If you enjoyed this session, please consider sharing it with a colleague or your clinic team. It genuinely helps us continue building accessible CPD for allied health professionals. And don't forget, if you'd like to finalize your CPD activity for this lecture, including the clinical summary PDF, reflection questions, and quiz, you can register free at clinicalcpdhub.com. Thanks again for supporting Clinical CPD Hub, and we look forward to learning with you in future courses.